Okay, is this on? Yes. Okay, so we're back in the room, back for the final stretch of the conference. And I'd really love to introduce Dr. Jonathan Harrold, who's a clinical psychologist at the Birmingham Centre for Excellence.
Afternoon, everyone. Jonathan Harrold here, clinical psychologist in Birmingham, and thank you for having me here today. It's a real pleasure to be with you. So what we know from the research evidence is that there's a consistent finding that people with long-term physical health conditions, including Behçet's, are more likely to experience mental health problems and emotional distress than the general population, usually impacting on mood, heightened stress, anxiety, trauma responses, impacting quality of life, grief reactions. The reasons can be complicated with multiple factors involved, whether they're biological, psychological, environmental, behavioural, relational, financial, the demands of dealing with a rare complex health condition and treatment. So lots of factors. So we acknowledge that living with a long-term health condition like Behçet's can be very hard with a far-reaching impact. So I thought we could spend a bit of time today thinking about the unwanted, whether the unwanted is thoughts, emotions, experiences, and thinking about that through the use of metaphor. While nothing will be groundbreaking or necessarily offering resolution, hopefully it might offer or strengthen perspectives of how we can deal with and respond to the unwanted, whether we're thinking about Behçet's, other health conditions, or just dealing with life. So I just told a little fib. I do have a resolution for dealing with the unwanted. It's fantastic and it always works a charm, and it's called avoidance. So it's absolutely great. Avoidance and suppression, brilliant. So, or is it? So let's have a think. So this is our first metaphor. So I'd like to imagine that you, or me, let's say me in this instance, you're in the sea, this lovely blue sea, and what I want to do, I want to just have a swim. I want to take in this beautiful blue sky and just the heat, this sun. That's what I want to do. That's what's important to me in this moment, having a swim on this beautiful sunny day. But then along comes this beach ball, and I don't want it there. It's a problem for me. So what do? I pick it up and I throw it, but it comes back. So I pick it up and I throw it that way. But the tide just keeps coming back. So I keep throwing it that way and this way. But what am I no longer doing? I'm no longer having my swim. I'm no longer taking anything in. I'm in this battle with this ball. It keeps coming back. So I've got another idea. I'm going to push it right down under the water. So it's great. I don't see it now. And I can kind of take in the day and the sun and the heat, but I can't swim. I'm kind of glued to this spot. And also, how am I feeling? It's pretty exhausting. And at some point, I'm going to have to let go, and it's going to come up with some force. So the beach ball represents anything we're struggling with actively and that we're actively avoiding. So in this context, it might be like an emotion, for example, or an experience. What else could I do? What could I do with this ball? I can't pop it, another one will just come back. What can I do? As what I could do is allow it to, I might be able to find some willingness to allow it to exist in the expanse of the ocean. So I might be able to find some space for this ball in the wide expanse of the ocean with its ebbs and flows. And if I find a way to do that, I'm then better able to have my swim or to do the thing that matters to me. In this case, it's a swim and enjoying the view. And sometimes that beach ball might be so far away, off the horizon, it's gone. Other times it might come really close by and be in my face. But there's that idea that if we accept some, we often get less. And that's kind of an idea with kind of that this metaphor promotes. If we kind of find a way to make room for what's unwanted, we often get less of it. So over to our next metaphor. But people often share with me some of the tricky thoughts they typically have, and tricky might be an understatement. But our minds can certainly be very busy and noisy places. And people often say to me as like a goal, I just want those particular thoughts to stop. I don't want to think this way. And this metaphor will perhaps offer an alternative approach to just stopping thoughts, because I don't think we can, and I don't know how to help someone with that. So in this metaphor, I'm a bus driver of my bus, you're a bus driver of your bus, you're a bus driver of your bus. So I'm a bus driver and I want to go in a particular direction. I want to go east. That's what matters. Whatever east means, that's where I want to go. That's the direction I want to go in. I can't control the road, so sometimes that road might be really smooth. Other times it might have some speed bumps. Other times it might have potholes. Other times it might be this really dusty, gritty, rubbishy road. I can't control that. I can't control the diversions on the route. I can't control the road closures. I can't control the bridge that should be there, but it's not. All I can control is going in the direction I want to go. But on my bus are some passengers, and these passengers, well, some can be quite quiet, some can be quite disruptive. And some of these passengers have got names that maybe you're familiar with. They've got names like doubt or fear or resentment or criticism or encouragement or joy or kindness. They've got those kind of names. And it's helpful for us to kind of recognise what voices are loud and what passengers are kind of close up to the driver's window. So if I want to go east, but I've got kind of criticism right up the window, who are you to think you can go east? You go west. That's where we always go. Who are you to think you can do something different? Or what if fear's behind that? What fear's at the window? What are you thinking going east? We don't know what's in that direction. We know this direction. Let's stay there. So there might be all sorts of passengers that are right close to my window that unsettle me, and actually they're bothering me. So I do what they want because that makes them quieten down. And that might mean it's a bit cut off there, but I go on the same old road. But I don't want to go on that road. I want to go on this road. And I suppose here it can be helpful to think about who might kind of mine, yours, our passengers be that are kind of loud and helpful, or loud and unhelpful. And which passengers do we want to hear more from? Maybe we haven't heard from adventure for a while. Maybe they're like upstairs at the back being quite quiet. What would be like what do they say? What about encouragement or kindness or compassion? What do they say? And like I say on this, we can't control the road conditions, but it's trying to make sure we're going the direction we want to go in, rather than being controlled by some of our more tricky thoughts, and trying to make the decisions we make about our direction through a place of awareness rather than that autopilot, because this stuff happens like that. These voices are so quick, we can easily get taken off, get taken in a direction we don't want to go in. So our final metaphor introduces the Japanese art of kintsugi. I think that's how you pronounce it. And kintsugi means golden joinery. And there's an example of it here, actually. In kintsugi, when a ceramic item is broken, the pieces aren't discarded, or the pieces aren't kind of glued together to look like it's exactly the same. It's glued together with gold. I don't know if people can see in there. So there's gold mixed in with the glue. And so the idea is that the pieces are taken care of and looked after and honoured, and then the item then becomes more robust and precious than ever before. And it's kind of a metaphor for acceptance and personal development and healing. It's the aim is to draw attention to kind of breaks and damage, and to draw attention to the work that's gone into repair and to heal, and to honour the kind of the the honesty and the beauty of imperfections. So this mug was sent to me from a friend in the pandemic. It's just got the name of a TV character we both thought was funny. And it wasn't a particularly special mug, and it's just in the cupboard. But then I broke it one day, and I was really sad because I thought, oh, that came at such an important time when we're all in lockdown, and I thought I don't want to just get a new one because it's not the same. So you can get Kintsugi Kids for about £10 from Amazon, which I did. And now it's on display, and now it's here. So I'm not going to drink out of this because I imagine it's quite toxic. So its use has changed, but in a way, it's even more kind of precious to me than ever before. So how do we kind of learn to repair or heal ourselves after adversity? So the method of repairing kintsugi is the gold. And when we feel broken or damaged, often our self-worth also is negatively impacted. And it's easy to lose sight then that we're deserving of self-care and nurturing, and to investing in those things in order to maintain our own health and fulfillment. So what might some ideas be of the gold? So I suppose there's kind of some here. It's human to do, like we've already said, it's human to want to do the top stuff. We'll all do that at times, but we want to use it sparingly. Thought suppression, avoidance, ruminating when we just go over and over and over. Just willpower, just pushing on, ploughing on. Ignore the body. Let's just push on. We want to use those ideas sparingly, and we want to use these ideas below in the main body of the triangle liberally. Non-avoidance, compassion, especially self-compassion, which is hard. Pursuing personal values. Relationships and connection to shared humanity. That's what this is all about. This is shared humanity. This is connecting with people that understand kind of some of your own experiences. I was really struck when Tony showed us earlier, didn't he, the photos of like the family away day or the away days and some of stuff like that. That's this stuff where we are able then to connect and to feel we're open to empathy to others, empathy from others, and compassion. It's essential stuff. At the bottom, mindfulness, we talk about that a lot, and I have a lot of time for mindfulness. I also think we don't talk about intentional mindlessness enough, and intentional mindlessness is really important. And this is when we're doing activities which kind of give us a state of flow when time just kind of goes by and we're absorbed in an activity. Is Heather here? Heather who makes the cards? Who's Heather? Is she here? No? So there's someone, I was looking at the cards earlier, they're fantastic. There's some Christmas cards by someone called Heather. And I just imagine when they're making those cards, time just goes by and they're absorbed in that task. Creativity is usually an intentional mindlessness, like when we're listening to music or creating music or involved in a task. That's important stuff. So some of this is some ideas of what the glue might be. I've got some resources here for if people are interested in these ideas of acceptance and compassion, because they are hard ideas. And I've got some resources. I've printed out some resources which I'll put on the table at the back at the end. Some are this size, some are half the size, so take the size that you need. And there's just some good books here that people might like, some good apps that people might find helpful. And the website I'm kind of quite keen on at the moment is this Kristin Neff one, this selfcompassion.org. Really nice one. With a condition like Behçet's, having to listen to body is essential, and mind doesn't always do what body wants it to do. Body might sometimes be saying, stop, I can't, and mind might be saying, oh, no, come on, this is who I want to be, this is who I am, we're going to keep going. But sometimes we have to listen to body, and in order to do that, self-compassion has got to be present. So some people might be aware of the approach called pacing. Some people may not. So pacing is kind of a really valuable and important strategy. And it sounds very easy and it sounds very logical. Pacing is very hard. And I don't know how you do it without the compassion. I just don't. So learning that skill is really important, or developing that skill. That's the end of my presentation. Thank you very much for listening.
Thank you so much. So I'm going to welcome Deva back for the last, I think it's the last, isn't it? The last of the day.
Well, thank you, Jonathan. That was excellent, and I learned a lot. And actually, I think you're one of those people who practices what they preach, because you're such a calm person, and I'm sure all the patients appreciate your approach. So, well done. Okay, so the next bit of this, the final session of the day, is about the how we've looked into the data that we could from our national data sets, including the hospital episode statistics, the clinical practice research data link, and I'm going to try and give you a flavour of some of the stuff that we found. And I can't go, of course, without acknowledging all the people on this slide. I mean, the many meetings we've had, not always in the pub, and particularly to Priyanka, who helped with a lot of this work, and also to my gastroenterology colleague, Carol Cobb, and Nigel Trudgill especially, because we go on a lot of walks as families together in Devon that do end in the pub, but this is where the ideas for these projects actually emerged. So first of all, just to remind you all about the reason that we do epidemiological studies, we can try and achieve all of the things that are shown on this slide, and I'm conscious of the fact that I know now one of our colleagues in the audience is an epidemiologist. And quantifying disease burden in population is one of those things. To compare one nation, for example, with another, to examine the actual detail of the conditions in each of those places, because they may not necessarily always be the same, as we've heard. And we've heard that in the Japanese and the population, we've seen that that's changing over time. We can look at the evolution of clinical manifestations of these conditions over time and compare disease outcomes. So all of these things are things that we can achieve by doing epidemiology, and we need registers to do them. And we can also try and understand the nature of the link between environment, nature, and nurture. And we can do that directly sometimes, although it's not often done, by studying what happens when migrants go from one part of the world where such a disease is common to a place where it's uncommon, where there has been a rapid change in the environment. Okay, so those are the sorts of things we can try and achieve. Oops, doesn't seem to be moving. Oh, yeah. So this slide here is, I'm sure you've seen it many times before. It just shows the prevalence estimates for Behçet syndrome in different parts of the world, and it just illustrates the enormous variation in the epidemiology that you all already know from many occasions of attending these meetings. And at the time this slide was prepared, Northern Europe's figure was 2, which came from some studies in the 90s that gave estimates of disease prevalence at that sort of level in England. Here's another slide that summarises a much larger number of studies done by Alfred Marr, who's an epidemiologist in Paris. And the nub of this slide is that the mean prevalence is 10 per 100,000 of the population worldwide. So that's what it all averages out at. But as you can see, in the top panel compared to the bottom panel, the prevalence estimates vary depending on the type of study that is done. So depending on the type of methodology, it will give you a different result. And you can see from this slide as well that there's this big variation, and wherever the little dots and the lines deviate from that middle line, and there's no line between the centre line and that dot, you know that that's a significant difference from the world population mean. So there are some important geographical differences. The other thing that we can see on the slide is that where migrant studies have been done, and there aren't that many, where you move from an area of the world where the prevalence is higher to an area where the prevalence is lower, then the migrants tend to adopt an intermediate risk. So that tells us something about the nature-nurture discussion that we were talking about earlier on. So the first study we did was using something called THIN, or the Health Improvement Network, and that's a primary care database with 3.6 million individuals in it, including 675 general practices. And it's broadly considered to be representative of the UK population as a whole, so we can extrapolate from this practice database to the general population. Okay, and it contains all the data related to patient demographics, the diagnoses, the investigations that they've had done, prescriptions and mortality data. So what we did when we looked in THIN is overall we found, to our surprise, that the prevalence of Behçet syndrome was much higher than that previous figure of 2 per 100,000, and actually varied between 8 and 14 over the 10 years of the study, and it was going up. And it was appearing to become more common in women than it was in men. We looked at some of the outcomes in that database, and here is a summary slide showing the mortality in patients with Behçet's compared to 3 matched controls that were taken from the same practice as the patient was identified in. So it was a carefully controlled study, and you can see that all of the lines in all 3 panels diverge, indicating that the mortality was relatively higher in risk, a hazard ratio higher than 1 for the Behçet's patients compared to the healthy normal people who are controls. And that was the case for the population overall, and for men in the middle panel and for women in the lower panel. We then also looked at some of the other elements of that morbidity and mortality, and we looked particularly at thrombotic complications, so blood clots either on the lung or in the legs, and also the risk of heart disease. And to summarise our findings, we found, as we weren't surprised to find, an increased risk of DVTs and pulmonary emboli in patients with Behçet's, because we've known that's a factor. And we also found as in common with other inflammatory diseases, autoimmune diseases, an increased risk of cardiovascular complications such as heart attack and stroke. So that reminded us that we need to take account of vascular risk factors in patients with Behçet syndrome when we're treating them, and perhaps consider those factors in children that we manage over a long period into adulthood for later life. One of the other things we found, shown on this slide, is the risk of blood clots, that's DVTs and pulmonary emboli, both at baseline when we made the diagnosis of Behçet syndrome, but also after we'd made the diagnosis. And what you can see is that the figures, the relative risks have gone down. And what we don't know from this is whether the reason for that is that we've done something good in terms of treatment and we've caused that reduced risk to occur by our treatments, which would be nice, or whether, in fact, the higher risk before the diagnosis of Behçet's means that we've used those blood clots to help us to make the diagnosis. And in fact, I think in practical terms that it happens both ways, that we do improve the outcomes, but we also find that having a Behçet's diagnosis is often triggered by an unexpected thrombosis in a patient, and that's what makes a clinician think, well, it could be this. The other thing that we did, which was quite by chance, was we looked at the incidence and the prevalence of other immune-mediated inflammatory diseases in the patients on their journey to getting a diagnosis of Behçet's. So what you see on this slide is, first of all, in our study there was 1,281 patients with Behçet's identified, and during the 10 years of the study, 444 new cases were found. And then what we found was, before the diagnosis of Behçet's was made, a significant proportion of them, 12.25%, had other immune diseases diagnosed, including the ones that you see in the bottom panel there: inflammatory bowel disease, psoriasis. Those are the conditions. And a few of them moved on to another diagnosis later. And again, there was what we thought was an overrepresentation of inflammatory bowel disease and psoriasis. So at the time, we weren't aware of this so-called MHC class 1 opathy concept that has since become a thing, but that does include some of those conditions that you've seen. So we've seemed to have picked up a link Problem with that, though, was that we had no control patients to see whether those diagnoses that had cropped up were any more common than by chance. So we needed to investigate that further. But just to remind you, this is a complicated slide that really Graham should be talking about, but essentially what this shows on the left-hand side are these sort of Venn bubbles, and inside those bubbles you see each of these conditions, the inflammatory bowel disease bubble, the psoriasis, Ankerspond, Behçet syndrome in the middle, Behçet spectrum disorders that Eslam mentioned earlier on. And then we see within those bubbles the overlapping genetic polymorphisms that have been identified and linked to those conditions. And the striking thing is that you can see that there is an overlap. In other words, the same genes that work in Behçet's appear to have an effect in these other conditions, but not necessarily in the same direction. It may be in one condition like Behçet's, it is associated with the disease, and in the other diseases, some of them actually are protective. It works the other way. So that was fascinating. And it also told us that the signature of all of those genes pointed towards factors in the immune system that govern the way that immune cells recognize peptides, process them, bind them, and respond to triggering things such as infection and things like that, okay? So that's telling us something about the immune mechanisms that are relevant in these conditions that are shared. So then we come to the MHC class 1-opathy concept that we've all been talking about throughout the day. And this was really based on the work that was done by a colleague called Jonathan Sherlock, who is actually one of our very clever Birmingham trainees. He went on to work in the pharma industry and is incredibly, clever guy. And anyway, he helped to discover a cytokine, IL-23, that Graham was talking about earlier on, and the relevance of that in the pathogenesis of a variety of immunoinflammatory diseases. And together with some other colleagues, that led to this theory that perhaps Behçet's was part of a spectrum, a group of diseases that shared this common biology, linking sensing and processing of peptides with genetic markers and linked in to barrier dysfunction, perhaps leakiness of those barriers that predisposed to the condition, and linked into stress areas such as in blood vessels and in eye and other areas. So that's the so-called MHC class 1-opathy concept, which is being investigated, and there's an international group that's been set up to do so. And so to summarise what we've found so far, Behçet's prevalence is much higher than we thought in the 90s in England. Patients are at an increased risk of ischemic heart disease, cardiovascular disease, and thrombotic problems. The potential mechanisms for those blood clots, which came up in one of the questions, could either be endothelial dysfunction, the lining of the blood vessel is abnormal, or it could be inflammatory mechanisms that we would coin immunothrombosis, linked in to having this autoimmune disease, or it could be a bit of both. We've got this burden of increased risk of blood clots before the diagnosis is made, and an alteration of that risk over time, possibly due to the effect of treatment. We also found that in the diagnostic journey to getting Behçet's, there seems to be an overrepresentation of the other conditions that are linked and can often be confused with Behçet syndrome on that journey in a small proportion of cases. So is that relevant somehow? So the next bit of the talk is focusing on some of the work that Priyanka did with us, and my colleague Nigel Trudgill and all these colleagues shown on the slide here, using the CPRD, Aurum and Gold, which are bigger data sets that we can access larger numbers of patients in the population in England and in Wales. And the methodology is shown on this slide, but basically we used an automated tool, an algorithm that extracted all the cases that were diagnosed with Behçet's from the UK data set, and it compared it with 4 controls for each case that was identified. And the numbers are shown up on the right. It's not very clear, but essentially we identified pretty much the same prevalence that we found in the Thin study. and I'm going to share with you some of the results. So here we see from a much larger data set the rising incidence of Behçet's over time, over that 10-year interval, but particularly on the bottom slide, the rising prevalence you can see over that interval, which is over a much more prolonged period from 2006. And overlaying on that, I've put this other slide, which is the rising prevalence of inflammatory bowel disease. That's ulcerative colitis and Crohn's disease, using exactly the same methodology from exactly the same database over the same period. And you can see that the same curve over time is going on for inflammatory bowel disease. So is that a coincidence, or is it actually connected? And is there a link between what's going on in inflammatory bowel disease and what is going on with Behçet's disease? We don't know, but that was a really fascinating thing to have emerged from that study that is worthy of further investigation. We see that this rising prevalence is happening in all regions of England, so we were able to split the data by the part of England affected and Wales, and you can see that the top of the one is green, and guess where that is? That's Wales. So for some reason, it's going up quicker in Wales, and we really can't explain this just at the moment. The other one is the southwest, where it's going up quicker. Now, quite what is the cause for that, I don't know, but it seems to be a significant finding. We also looked at the effect of race, and to be fair, the data on that that's recorded isn't ideal, and there's some missing data, but we did find that there appears to be a signal for ethnicity, and we're finding a higher prevalence amongst those of mixed race and other ethnic groups. So that's, again, worthy of further looking. But what we can't do in our database is to look at the migrant status or any of those factors down at an individual level. But look at the sex data. And so this is the graph for the women and the men, and you can see that the curve is going up quicker for women than it is for men. And there is a sort of glimpse of a rise in incidence as well, more so for the women than the men. So again, this is in contrast to certain parts of the globe, like the Middle East, where Behçet's disease syndrome is said to be more common in men than women. Whether that's truly the case, we don't know, but it's what's reported in the literature. This contrasts quite greatly with that. So the other thing we were able to do was to actually look within the GP database at all the individual elements of the Behçet's phenotype. That's mouth ulcers, genital ulcers, uveitis, epididymitis, folliculitis affecting the skin. And we were able to track the appearance of those items over time in that large cohort to see how that associated with the diagnosis of Behçet's, which is right over on the left-hand side where it says BS. And you go back in time and you see all the things that occur. So essentially that describes a journey for the patient and for the biology over time, where different things seem to start first and then spread to another organ and then to another organ, and then the diagnosis is made, and then you're labelled with having Behçet's. Now, we, as Eslam said, have an artificial construct to say that Behçet's is when you arrive at this point in time. But obviously, you don't just suddenly get Behçet's overnight. There is a journey that you go on, and very little attention is paid to what's going on in that journey in the precursors to Behçet's. And we don't know whether that precursor state for Behçet's is common only to Behçet's, or whether it overlaps with some of those other conditions which share the phenotype or certain phenotypic elements that link into the Behçet's syndrome. So again, that's another area that is worthy of further study, especially so because of the genetic data that I showed you, which we can see there's strong genetic overlap. And that's something that is well recognized in the genetics field. And there is a name for it, but it's completely gone out of my head. Okay, so then the final bit of my talk is more to do with the hospital episode statistics. So what that is the data system that we use when people come to the hospital for treatment. And they should all get coded with their diagnosis. and we should be able to collect all the data from them. The problem with this is that they come to hospital as an emergency and they almost always have their diagnosis coded, but when they come to the outpatient clinic, they don't necessarily get it coded. So it depends which hospital you go to, and that varies. So we don't get completed data collection, and we're going to be seeing the more severe end of the spectrum when we look at this HES data, okay? But once again, we studied over a period from 2011 to 19, and we found our prevalence was much lower at 2.2 to 3.8, which is not surprising given what I've told you. Once again, we found that even in the severe end of the spectrum for Behçet, we found it was more common in women as opposed to men, and it was a relatively young mean age. And one of the other things that we found was that the prevalence of Behçet syndrome appeared to be higher and associated with the index of multiple deprivation. So there's a strong link with socioeconomic status, and that link is the risk goes that the more deprived you are, the higher the risk you have of Behçet's. Obviously, that's not a sort of strict linear relationship, but it's an important factor because it links into some of these environmental factors that interact with genetics that we were talking about earlier on. Here is the graph of the prevalence over time, okay? And as I said, it was 3 times lower than the CPRD studies that we've done, not surprisingly, because the coding occurs following inpatient, day case, and outpatient care. So it's the severe end of the spectrum. So we can also compare our centre of excellence attenders versus the non-centre of excellence attenders. But there's a health warning on this data because we can't rely that every case that attended a centre of excellence has been captured in this, okay? We're pretty confident that most of the cases in Birmingham were because we've just gone obsessional about doing it because we were doing this study. But that's not necessarily a case in all other centres. But what we did find, once again, is whether you went to the centre or not, there were more women than men, but there appeared to be more comorbidities amongst the patients that attended the Centre of Excellence as opposed to those that didn't. Whether that's a real thing, again, we're not certain at the moment. What we were able to do too was to compare the use of treatment in those two groups of patients, and what we found was treatment with infliximab, that's a form of anti-TNF therapy that's given intravenously, so you have to attend the hospital as a day case to have it. That was more common at the Centre of Excellence than it was in the patients that hadn't attended. But what this data doesn't do is record all the patients that got other forms of anti-TNF therapy that aren't given by an infusion, such as subcutaneous injections delivered at home. And we cannot access that data through the system, unfortunately. So what we then did is we wanted to do a multi-variable logistic regression analysis to try and understand the interrelationships between all these factors and whether any of them have an independent effect on the outcomes. So what we found was all the factors that we recorded were age, gender, ethnic group, deprivation quintile, comorbidities, attendance at the Centre of Excellence, and whether you got infliximab or not. What we found was, when we did this analysis, that non-Behçet symptoms and GI, gastrointestinal manifestations, were highly significantly associated with the female sex. So that's something they observed in Japan as well. We found it in the UK. That's probably a subphenotype. Male patients with Behçet's were more likely to have ocular, vascular, and cardiac manifestations of Behçet syndrome. Caucasians had a higher prevalence of non-Behçet's related symptoms. Asian ethnicity was associated with a higher prevalence of ocular Behçet's disease complications, and non-white ethnic groups also had a higher prevalence of vascular, neuro, and genital ulceration. So those findings were fascinating. There's more work being done with this because we were able to link the CPRD with some cases in the HES data. So there's a bit more work to be done on that is being done as we speak. What we also have, I'm putting up a slide of the process that we have for our patients that attend the Centre of Excellence. And these are the patients that have attended the Centre of Excellence, been diagnosed with Behçet's, and remain on our system at the 3 centres over time. And what you can see is that that line is obviously going up too, really in parallel with all those other lines that we've seen. Unfortunately, what we couldn't do is join up the dots and connect these cases directly and link their data with this national data. And we're not allowed to do that. So again, I've talked about the multi-logistic regression. All those factors were not associated on the top panel. What we did find, not surprisingly, is the older you get, the higher your mortality risk. Well, that's not a surprise, unfortunately. It'd be nice if it wasn't. What we did find, though, is mortality was lower in the least deprived quintile. Well, that's not surprising because that's what we find with virtually everything else, but it's also prominent in the Behçet's patients. It's a factor. What we also found was comorbidity score. So that is, if you have other diagnoses along with the diagnosis of Behçet's, you are more likely to have a problem in terms of mortality than you are if you've only got fewer comorbidities. And then what we did find also, which is I was pleased we found, although I shouldn't say that obviously, is that we did find that infliximab appeared to impact on mortality, which is good. So one of the other things we did, going back to one of my earlier slides, is because we hadn't fully examined this MHC class 1-opathy concept, is we were able to look at that as well, and we were able to compare how frequently patients with Behçet's syndrome on their journey had these other conditions compared to control patients who didn't have Behçet's. And what we find by the little asterisks in green is a highly significant link with these other conditions that have genetic overlaps with Behçet's syndrome. So we confirmed what we found, and it was highly significant for all of these things, particularly for inflammatory bowel disease. But all of these, there could be a potential genetic explanation. So getting back to our earlier slide, the population of England, 53 million, we've got these MHC class 1-opathy conditions, of which there is 5 minutes to go, a larger group, the FAPA syndrome, which is another large group. It's said from some studies that about 30% of Behçet's patients who are grown up with Behçet's can recall a history of FAPA in their childhood. That's the Italian people who've discovered that. So could they be part of this journey to getting Behçet's in the first place? So there's plenty of further stuff that we need to look at here. Why are there so many cases in the primary record? Why is the prevalence going up? Hopefully examining the HES link in CPRD will help us with that. Why is the prevalence rising? Could it be partly linked to the journey to Behçet's and some misclassification with inflammatory bowel disease, particularly, which is going up and is sometimes hard to differentiate? Can we identify a pattern prior to the onset of Behçet's that will indicate that this is going to happen? And that's something for the future. That's why we want to think about AI and the omics to try and help us with that. And there is this EULAR study group looking at the MHC class 1-opathy across the world now that's been set up to try and investigate the mechanisms and some of these things. So hopefully our data will help with that. And so I put this slide up really because some time ago I was asked to give a talk at Philip Murray's retirement do, although he hasn't actually retired. He's still working. But we had to all come up and we had to give a talk. And I was asked an amazing question that is, in 20 to 30 years' time, what will be the Behçet's clinic be like? So I was thinking, whoa, what do I say? Well, the first thing is that it won't be just me and my colleague ophthalmologists and oral medicine specialists and ologists there. It probably would be a data scientist. It would be a geneticist, because we'll be better at unraveling all the genes that are linked in, some of which Eslam has talked about. And it probably would need to have a data scientist who's good at AI and allowing us to join the dots up better so that we can connect up these big data signals that we've been looking at in HES and all of that, linked into primary care, to connect those up with the clinical things that we measure and with the omic signatures that we can potentially now measure and could measure much better in the clinic. And then what would happen is we would have a massive signature for patients that begins to be a lot more complex, but possibly we could learn to recognise better patients who have the condition and those who don't, and how they're going to go forward into the future, what's going to happen to them, all these things, we'll be better at that. That was my vision for how we might be functioning in our clinic in 20 years. Unfortunately, sadly, I'm not going to be in the clinic, which is a great sadness to me, but I'm hoping that with the help of the Behçet Syndrome Society, we will get there. And the final piece of the coin that Graham, I suppose, referred to in his research summary is the microbiome. And I read The New Scientist on a regular basis, and I'd strongly encourage you to buy this particular article, which is only, I think, a month ago, wasn't it, Graham? It was a big article on the microbiome, and it sort of exposes a lot of myths, but it also tells you a lot about the potential of our microbiome and how we actually are working in partnership with these microbes, and they are shaped by our genome as well as them shaping what happens to us. So on that note, I'll finish.
So we're going to move on to the medical panel now. So if this is an opportunity for you to ask questions to the medical experts within the room and online.
So I think we've got some questions already submitted. One of them I think I'll answer because I think I know who asked this question. I'm looking at her. Because she was saying, well, you've talked to us about the familial risk for inflammatory bowel disease. And it is important that you make people aware of how small that risk is. And that is very important. I hope I've not misled people thinking, it's highly likely that you're going to get Behçet's. From the data that I presented, the absolute risk of getting Behçet's, if you're a family with Behçet's in the family, is very low. Okay? I could give you a number for that, but I think it would be artificial because the study that was done didn't follow up all the patients forever, okay? And so there was only a finite interval during which time they were followed up. So they didn't refer to their risk as per person, they referred to it as a person year of when they were at risk. So it isn't something you can directly equate to reality, okay? So that's answered that question, hopefully. But remember that the familial risk in the families with Behçet's, they contributed only 4% of the cases overall, so that gives you an idea. Okay, so there was a question about diet, and that is, I'm going to ask Graham to answer this question, which is that, is there a specific diet that we should follow? And leading on from that, there were some other questions that we've already answered, which is, should I go on a probiotic diet or not? So, Graham.
Well, the first answer is no, there's not a specific diet that we could recommend because there haven't been the studies done for this. I think that from the work from Giacomo Emi's group, then something like a Mediterranean diet would not do you any harm. It's recommended for people that don't have diseases as well. So that would certainly be something that you may want to consider of moving more in that direction. But until we've actually done the studies where we've, as Giacomo was trying to do, putting people onto a particular diet to see if it alters the Behçet's, then I wouldn't say that there's one diet that you're looking for. The advice you get always with diets is to obviously be high in fibre, lots of vegetables, kind of keep away from too much red meat. The basic elements of what you'd hear from lots of dietary advice. And I would suggest that that's the way forward. But this is something that we're looking at. From the probiotic aspect, again, there's nothing out there at the moment. Again, the use of butyrate that supplementing diets that Giacomo's doing, that may well be something that we could consider taking forward. But again, we'll need to wait until we see the final figures for this. So the healthiest diet you can take will help you regardless of anything else that's going on. And I would leave it at that for the moment.
Thank you, Graham. I'll ask if Daniel's still online, I'll ask him a question because one of the, I think, online participants asked the question, who trains the ocular artificial intelligence? So I think what that is, Daniel, is how do when they do their deep learning processes for their AI, looking at pictures of the retina, and then they use that data to extend it to predict other diseases, who would actually code or label that data? I think that question, the answer might bring out how there's a self-learning element to it, and then how a person might then code for certain particular things.
Yeah, absolutely. So hopefully you can hear me. So there's a common process that happens with this type of work where you can do this sort of unsupervised pre-training, we call it, which is where you take a lot of data that's good data, but it doesn't have labels, which means someone hasn't sat down and assigned, okay, this image means one thing, this image means another. That labeling is like the hardest thing to do, the most expensive thing to do with data. So if you can make use of unlabeled data, that's often really good. So what we can do is train a model based on unlabeled data that is available maybe from collecting data across public data sets or working together with different organizations, collect as much data as possible and train a big model that kind of learns a representation of that data. So the model's not trying to actually really do anything at that point. It's just trying to represent all of that data. And once you've done that, which can be done by one team, then that trained model can be used for downstream tasks. So maybe we want to be able to identify a certain disease based on an image of the retina. You can then take a much smaller labeled data set that's maybe collected during a smaller study and labeled, which is expensive and requires a lot of expertise. And you can combine that pre-trained model that we created cheaply using the large unlabeled data set with the small set of labeled data set and train another model which combines them both and allows you to have insight around that particular problem. So that's called transfer learning, and it's a way that we can apply these kind of big high-level efforts in the solution of other problems that are kind of a subset of the whole. So that's a really effective pattern. It's helps save costs and simplify situations, and that's very common to be used across industry and in medicine.
Thank you, Dan. That's really helpful. Good. And the other cool thing I know that you and I have had in talks is how when they do this unsupervised learning, that it's like, imagine, you explained it as going into multiple higher dimensions, constructing the data set into almost a multi-dimensional representation of the data. And then you can look at the associations between these little collections of data in this multi-dimensional hyperspace, which I thought that's amazing. And it's so good that we can do that. Oh, okay. Daniel's gone. Okay, so the next question related to the role of antibiotics exposure. And it was a clarification because in my talk earlier on, I think I said antibiotic exposure modulated the risk. And that wasn't clear because we didn't know whether it was modulated it up or down. And actually, the antibiotic exposure in familial inflammatory bowel disease appeared to increase the risk of getting the problem. Okay, so that is if you're an unaffected individual, but you have a family member who has the problem, and you then take antibiotics as opposed to not taking them during childhood, especially broad-spectrum antibiotics, then it appeared to increase your risk of having inflammatory bowel disease. However, Graham reminded me that there's a health warning on that because that could be interpreted in a number of ways. First of all, it could very well be that the antibiotics disturbed all the bugs in your bowel. That change in the bugs in your bowel then modulated your risk and made it more likely that you would get inflammatory bowel disease. That's one explanation. The other is that it could be something to do with the antibiotic itself, unlikely, but possible. Or it could be that the very reason that you were given antibiotics in the first place was that you were developing symptoms of inflammatory bowel disease. There was misdiagnosed as an infection, and therefore you saw your GP and got your antibiotics. And in fact, in practice, it could be all of those things. So I did speak to one of my gastro colleagues when I saw this paper, and a number of other papers, and amongst the gastroenterology community, they don't take this that seriously, but I think that's a mistake personally as well, but I think it is telling us something, but yeah, so that responds to that question. So there is another question on here, which is more about steroids, and is there a leaflet available on steroid therapy? Eslam, would you like to answer that?
There are lots of leaflets available. I think most hospitals and most rheumatology departments will have some information about steroids that they can share with you. But I'm not aware of any one version that is more true than another, but most hospitals will have drug information leaflets before they put you on a particular drug.
Yes, thank you. It may be that was an international query, because I'm not sure how available these leaflets are in all parts of the world, but certainly standard practice in the UK to have the leaflets.
From a paediatric point of view, there is a website called printo.it, and there is lots of information about different medications used in all sorts of rheumatic diseases, including steroids. So if hopefully that might be helpful.
Yeah. Another question here was the referral process to the centres of excellence. This is a very good question because it's exposed a weakness, and that is basically it's hard to get to the centres sometimes for patients, and it's hard to get referred and also to persuade your doctor to refer you. And then when you are referred, not all of the information about you goes to the centre of excellence, and then you have to go through the whole process again and get it all out. And so should there be a better process for collating that information in advance and then transmitting it? And that is a very good suggestion, and it's actually something that one of my colleagues, Sangeetha, who isn't at the meeting today, has repeatedly said, Deva, you've got to get this done. And I say, yep, we'll get this done. And then I produce something, or she produces something, and I look at it, and then nothing happens. And we've got to get progress with that, really. But I feel the reason it hasn't happened, because we tend to do these things with paper, and it can't be a paper process. It's got to be electronic, and then it's got to be accessible across the breadth of the NHS. And then it gets all very complicated, and you sort of lose the will to live. At least I do. So that's that question. I think we've come to the end of all our other questions, unless, Gemma, have we got any other ones at all, or are there any questions from the audience? Are there some more online?
So the first one here is chronic headaches / migraine with aura /stroke SUNCT in capitals, or paroxysmal hemicranes be part of Behçet's?
Right. So it's a shame we haven't got our neurologist here amongst us, but I'll answer for that, because we often have this conversation in our Behçet's clinics because many of our patients do have headaches. And the answer is that the cause of headache is multifactorial. And in general, it isn't to do with the Behçet's. Very rarely there are scenarios where Behçet's can cause a headache. And one that springs to mind for every patient, I'm sure, is that where they're having a blood clot in the brain, what we call a cerebral venous sinus thrombosis. But that is unusual and has particular features that help clinicians to recognise it, and there's scans that can be done to pick that up. But in the most cases, Behçet's doesn't cause headaches directly. It's indirectly through other mechanisms, and that will include tension and stress. It could include, and it did so for one of the patients that we saw on Friday in my clinic, the use of opioids on a regular basis. And this is actually something quite hard to explain to patients, that you could start taking a powerful painkiller, an opioid-based painkiller for a headache, it works, and then you carry on taking it. And then the cause of the headache in the future is not the original headache, but the fact that when you try and stop taking your medicine, you get a headache, and it's due to withdrawal from the opioid, so-called opioid withdrawal headaches. And it's very hard to persuade somebody who's got these recurrent headaches to then say, well, you've got to come off your medicine, the painkiller, for a month, and you'll get worse before you'll get better. But then you will be better. And so that's the conversation that we have to have in clinic. In our clinics also, I'm sure in London and Liverpool as well, we have a migraine protocol, which we follow, which is an escalation of various drugs that we can recommend for migraine, which isn't directly associated with Behçet's, but is quite common. And so, once again, we can recommend people to go down that pathway.
Thank you, Deva. Another quick one here. I wonder if international rates of male-female reflect stigma and systemic sexism in those populations. Men are listened to and treated, women's symptoms are dismissed. I'm sure that probably is a factor. I just wanted to make a comment that 70% of our members are on benefit, and that chimes with the comment that you said. Yeah. And my frustration is that because we don't have a registry, I don't know the patients that are at the centres, and so we haven't got one consolidated list of everyone in the country. So I'm sure that is a case.
That's a very, very salient question, because we were talking about that, and why it is that wherever we look, we seem to find more women than men, apart from in certain parts of the Middle East. And it could well be that there are systematic mechanisms which mean it's more difficult for women to go and access and get a diagnosis. We don't know, to be honest. And I can't answer that question reasonably because I haven't got my colleagues here in the room with me. I think they historically, Graham might answer this question, but they have been of the opinion that there is two sorts of Behçet's, and that there is the one that's in the Middle East, and then there's the rest.
Yeah, I mean, I think that the two grading categories that Eslam talked about, the ICBD was something that was generated, particularly driven by our Iranian colleagues, because they felt they were seeing lots of people that did have Behçet's but were not classified by the ISG. So there is generally it's a milder form. So more people will be included because of that. And there may be elements of it, certainly for the ICBD, that it puts more men into categories than it does women for whatever reason, just depending on the various lesions that they have. But yes, I mean, the idea, I mean, the Japanese have talked as well about complete and incomplete. So we may be, even in all countries, we may actually be looking at a spectrum of disease, more a syndrome, as you say, rather than everybody's got the same conditions as such.
And I mean, one of the things that Graham and I often have conversations about is the ancient origins of Behçet's and the genes that link in with it, and how they sort of came out of Africa, intermingled with the Denisovans and the Neanderthal genome. There's an admixture, repeated cycles of that, and then migrations across the globe toward the east and Indonesia and Australia. And the genes, consequently, are not distributed evenly across that geography. And those very same genes have persisted in the population for very good reason, because they are thought to be protective against particularly enteric infections, viral infections, things like the bubonic plague, all of these things. So that's why they're there in the first place. So they're disproportionately distributed across the planet amongst the population, and it's not unreasonable to think that that might have an effect on many other things to do with diseases that are linked in with the immune system.
When Svante Paavo first sequenced the Neanderthal genome and then showed that modern humans do actually have Neanderthal genes, he said he got about 50 or 60 letters from people. It was all women said, yeah, I think my husband is Neanderthal. So there may be another gender difference.
Right. Got another question here. Is there any active microbiome testing going on within BD cohort?
That table that I put up, there's been several studies have been done. We don't do it routinely, and it may be something that needs to be considered as far as that's concerned. As I said, if you look at just the different species that are altered, then there's quite a variation across the board. But when you start looking a bit more closely at the genus, then I said you're picking out these ones in particular groups. And that may be linked into what we're seeing. This is what actually generated the butyrate studies from Giacomo Emi, as he figured out that the bugs that were at the genus level were involved in producing these short-chain fatty acids. And then he looked for butyrate and found it was down. So there is no study that's going on to look at whether the microbiome is associated, for instance, with different manifestations or responses to treatment. But that may be something that we do want to have a look at in the future. The other thing that we're not quite clear about, obviously, is because of Behçet's having so many different sites in the body being affected, there are different microbiomes. So there's a very large oral microbiome, which has also been identified in some studies. There's also a vaginal microbiome, there's a skin microbiome. We've got $2 million from the Americans to look at periorbital microbiomes, so microbiomes in the eye. And the question would be, is the gut microbiome driving all the manifestations or any of the manifestations in something like Behçet's, or are these other microbiomes involved? And we haven't really done anything about, apart from these 3 studies looking at the oral microbiome, we haven't actually linked it together. And there needs to be more work done on that, certainly.
Thanks, Graham. Another question I've got, there was 2 questions. I'll do the first one quickly first. Should Behçet's patients with GI issues be under the care of a gastroenterology NHS team? My GI issues with Behçet's are treated by my GP.
That's a tricky one. I would say if you've got Behçet's, then you're obviously going to be most likely going to be under a specialist, or you should be. And we would sort of advocate that that person's case should be managed in partnership with the gastroenterologist, and that's what we do in Birmingham. I'm sure they do it in Liverpool and in London. And we actually have a gastroenterologist that regularly comes to our clinic on demand when the need arises. And that's even more important in children. So Eslam might want to comment on how relevant that question is to the paediatric population.
I think it's an important one because there's a huge overlap in symptoms with things like celiac disease and IBD, obviously. And so right from the diagnosis and understanding which child needs to be further investigated. And then we find that the advice of our gastroenterologist is invaluable, at least in explaining to the parents why their children might have certain symptoms, even though there might not need to be any long-term follow-up with the gastroenterologist, but they could give invaluable advice about diet, about how to observe certain symptoms, and so on and so forth.
Yes.
Thank you.
And then there's another issue, again, in adults, but particularly in children, where, and I think one of the questioners online pointed this out, is that they were having particular problem with perianal abscesses and lesions. And when we do our clinic, particularly with pediatrics, but also in the adults, we often have patients who come with a history of gastrointestinal problems and then perianal disease, that some of which that is due to, we diagnose it as being due to Crohn's disease, because that can characteristically do that, but you can't do that without a gastroenterologist on your wing. Or it actually is due to Behçet's, and it's part of that Behçet's phenotype. And so it's really incredibly helpful to have a gastroenterologist involved.
Thank you. There's a related sort of question too. Should Behçet's patients with migraine issues be under the care of a neurology? My migraine headache difficulties with Behçet's are also treated by my GP with prescription medication for migraine. I had a neuro episode with Behçet's where I needed to be hospitalised in 2018, but no episodes like that since. Now, this is from Emily, and she's named herself, and I don't know whether she's in the UK, but if she is, my recommendation would be that she ought to persuade her GP to get, if she's not being seen by one of the centres of excellence, needs really to get to a centre of excellence.
Yes, and we usually do manage our patients with the neurologists. And actually, quite often, our neurologists, and I'm sure the ones in London and Liverpool do the same, we can get them involved with interpreting scans, even if they haven't seen the patient. So we can get scans sent, review them across the NHS by a system called PACS, look at the scans remotely and give advice to the local clinician. And actually sometimes where we've had particularly difficult cases, we have had our scans and we've sent them, I don't know whether you're allowed to do this, but we have sent them to abroad to the experts in the Middle East to have a look at and comment on. And, it's easy to do that now with technology nowadays. Yeah.
And actually our medical council guidance tells you to do that as a clinician. You seek advice from whoever knows it. So it's quite correct. One from IAD here. Is there a possible connection between primary lymphedema and Behçet's disease alongside additional symptoms like excessive sweating and respiratory issues?
Not as far as I know, to be fair. But obviously, one of the things I learned when I was a hospital manager was the 5 whys, right? Which is a powerful tool, which is that when somebody tells you something, you say, well, why did they say that? And then you do that 5 times and you get down to the root cause. If you do that with this particular question, you then wonder, well, is it really lymphedema? Or is it, if you've got Behçet's, is it a deep vein thrombosis and the leg's swollen due to that? And are the complications that are being reported something to do with that? But without seeing the patient, obviously, you can't actually comment.
Sorry? Is he right? Yeah.
Yeah.
There's a similar sort of theme that we had here. Please can you answer whether there are any protocols for improving interdisciplinary teams working together more closely treating Behçet's patients, i.e. rheumatology, ophthalmology? Well, of course, that's the concept of the 3 centres of excellence, which the highly specialised service hail as a way that we should move forward. Integrated care systems that are coming in the UK is meant to join up everything. And if they eventually get a grip of patient data, so everyone has one-time entry used many times, then there is a real hope that you can do this with all the socioeconomic things as well.
Yes.
But I don't suspect there are any particular protocols for it.
No, but it is an important point because, and we know this from our conversations with Eslam at the Children's Hospital and his financial managers and the conversations ongoing, it's an expensive business doing these multidisciplinary clinics. And the hospital managers, they're not against them, but they do regard them as being an expensive modality of assessment and treatment. Medics, on the other hand, think that they're very, very cost effective because we can get to see a patient with all the specialists in one place and then get an answer to a question that might otherwise have taken ages and involved many, many different doctors and wasted a load of resource. But it's very, very hard to get things like that accepted in the NHS. I mean, you've got to have you've got to write a business case, and then you write the business case and it's got it all in, all the money's in there, and then actually what happens is there's a financial crisis and they take some of your money away. I hope these guys aren't listening to me, but basically this is what happens. And then you end up with less money than you started, and then you can't afford to pay for the people to come and do the clinic. So it is interesting because one of my colleagues pointed out that the system as it is in Wales, which is far more joined up and doesn't have these boundaries, it's much more conducive to doing things like that because we don't have to cross-charge each other money when somebody goes here to do a clinic and there to do a clinic. It's all much more integrated. So hopefully we will move forward in that direction.
Very specific question here. Is there any treatments for Behçet's related esophageal ulcers? Sorry, I don't know how to pronounce that. Esophageal.
Yes. Well, it is possible for Behçet's ulcer to affect the esophagus, but it obviously would have to be properly evaluated, and we might consider systemic therapy for that if that was appropriate. All right. Anything for Daniel? Any more IT questions for Daniel in terms of machine learning? Because he's still online. I don't think there is actually, so I'll say hello to Daniel later and thank him.
I've got another quick one here. There's a few we'll have to answer, I'm afraid, afterwards because we will run out of time. But my daughter cannot control her body temperature whilst having a flare-up. Her heart and up over is hot, but her limbs are like blocks of ice. Is this a symptom of BD?
That's a very tricky one. I'll give that one to Eslam.
You just know which ones to pass on. I don't. I can't answer it straight one way or another. It sounds like a very specific and complex manifestation that probably has to be taken in the context of everything else that's going on, and without knowing the deeper details of what's going on with the patient, it's probably difficult. But in general, we don't see that in the pediatric population.
So I missed the second part. It said cold and it's anonymous, so cold and clammy is the best way to describe it. But yeah.
Just from a paediatric nursing point of view, so any child that has pyrexia or a temperature, generally their external extremities do go quite cold. So hands and feet tend to go quite cold with the temperature. Yeah. Oh, is it a temperature? Is that what you're asking? Is the temperature actually high? Yeah.
Yeah.
But with a temperature that's high, it can be quite common for the external sort of extremities to go quite cold.
I mean, there is, and obviously the auto-inflammatory conditions, particularly the ones that Eslam was referring to in childhood, or monogenic mimics, these disorders can have fever as part of their manifestation. So when we have, that's one of the things that would alert us to the possibility of these conditions, like age under 5, fever, consanguinity. These things would be. That's why it's important to verify if it's a temperature at all. Yeah.
So always do to panic. So that's in your ear.
Right, there's still quite a few here. Sorry. There's one from, I suspect, from abroad. I have come to Behçet's from USAID diagnosis. I have had fever symptoms since childhood, but symptoms became more significant in regards to my blood vessels and skin age 17. When skin ulcers became severe at 22, just after a long hospital admission. As the thiopurine has improved my skin symptoms, my son has started getting folliculitis and morning fevers. What is the chance it could be the beginning of something which might become Behçet's? Is early treatment useful for children?
Well, I think that's virtually impossible to answer, and really that's why we've got our paediatricians and clinicians to see those patients promptly and sort of go into it and take the history methodically, work out what the differential diagnosis is, rule out infection, and so on and so forth. So I think that person needs to really go through that process.
just put one up here now, because I think that's all we have time for, but we'll answer the other ones. I'm sure Deva will just try to finish them off before we close down. But this is from somebody. I just wanted to say how beneficial it has been to have contact with the Birmingham Centre of Excellence recently. I was diagnosed back in 2003 by a local hospital in another area. And after a repeated turnover of staff, asked one of the nurses about referral to the Centre of Excellence. Best move I ever made. It feels like I can now get my team in the local hospital to look into the Centre of Excellence expertise if and when crisis hits, as it did recently. I'm so pleased a member of original team told me about Behçet's support and a rheumatology nurse supporting me to seek referral.
That's very nice. Thank you.
That's probably a good way to finish off.
Yes, very good. Well, I mean, I'd like to thank everyone for coming. And, well, were you going to do that, Tony? I can do it. Okay, well, I'd thank everyone for coming. I mean, I really enjoy these meetings. They're tiring, but they are good because you learn so much. And, I mean, I think the links between the doctors and the patients and the society is quite a powerful one. If we all pull together, we're going to get a far lot more done than working against each other. So, and I think the Behçet's is a good example of this happening. So hopefully long may it continue. And Tony will get his wish of a national register. But we'll have to wait for that one.
Great, thanks, Deva. Great. Well, what can I say? I'm sure you'll agree it's been a highly informative and engaging conference, particularly noting all the questions, and we had a myriad of late, most of which have been answered throughout by our experienced panel. Thank you to those who submitted questions in advance as well, and we will get back to those other ones we haven't answered. I must conclude by thanking all who've made this event possible. This is our second hybrid conference. And thank you to Martin and Ian from Aston Media for again facilitating all the technical and presentational aspects so well and flexibly. Thank you to Dr. Deva and his team from Birmingham and elsewhere, e.g. Daniel and Anne Moll, and of course Professor Graham Wallace from University Hospital Birmingham. He works closely obviously with the whole community, but he's strictly speaking not part of the Centre of Excellence. For sponsoring and contributing to the conference this year, and I'm most grateful to all the panellists for your valued contributions today. I know our members will have found your input and advice most helpful and reassuring. It has to be remembered and emphasised that all of you don't just look after Behçet's patients, and as we all know, the NHS has been under considerable strain for an awfully long time now. Thank you to all the additional clinicians, nurses and trainees around the country who have helped our patients, most of whom won't have heard that message, but anyway, we are very grateful. And one has to remember that there are massive hospitals and GPs and clinicians helping individual Behçet's patients. To those of you joining us abroad, I hope you found this useful. Behçet's is very much an international challenge, as you've already heard Graham and Deva, for instance, mentioning, and needs to be addressed in a collegiate manner. It just needs a bit of a strategic roadmap, medical roadmap, as far as I'm concerned. A special thanks to Gemma Darlow, who has done a considerable amount of work behind the scenes, which has helped ensure today ran so smoothly and professionally. It is in... You haven't featured Gemma on the screen. Come up here, please. Come on. I should have bought some flowers for you. I should get some flowers sent to you. I apologise. In that regard, a couple of words she's reminded me about feedback process, which Gemma set up. So please, can you make sure that it was posted online in the chat for those online, and I think most of you have filled out the ones here. It really is important. We must take up your considerations into account when we do the next conference. I thank again my fellow trustees for all they've done. For those here in Telford, make sure you do log your car in before you go, if you haven't done it. The app apparently on here didn't work. Otherwise, you'll get charged an enormous amount of money, I think. And then finally, and lastly, not least, to all our Behçet's patients and their carers and relatives, I trust you found this a valuable day, which, judging from all the questions I sent you, have. It's for you that together we do all these things and to assist you through your difficult journey. I commend you for your determination not to let Behçet's get the better of you, and the more informed we are, the more we can assist you, basically. So I'll conclude by emphasising that to move forward, we really need to capture data in a forthcoming patient registry. All the best to everyone. Have a very enjoyable remainder of the weekend. I hope it's not too wet and you get home safely. And if you can put your bits and pieces in the box as you leave, please, yeah, which Gemma's got, that'd be great. Thanks very much.